Hi everyone, it's Mohammed Draz again, and this is the Brain, Spine and Beyond video podcast. This is a platform for inspiration, innovation, and invention. We started our podcast a few weeks ago with our first guest, Professor Peter Hutchinson, and today we have a special guest. We have Dr. Robert Masson. He's joining us from Orlando, Florida. He's an expert neurosurgeon, he's an inventor and innovator, and he's also the founder and CEO of Expanded Existence. Dr. Masson, thank you for joining us today and giving us the time to join us for the video podcast for Brain, Spine and Beyond.
Thank you very much, Mohammed. No, it's a pleasure to be here.
Thank you. So I'll start. My first question is, if you can take us through your neurosurgical career, your other activities, as it sounds you're doing a lot of other things beside your neurosurgical career. So if you just give us a quick overview of that, then we can jump into other interesting discussions.
Yeah, no, thank you. I mean, for the concept of brain, spine, and beyond, I think it's worthy to go all the way back to the beginning. I was blessed to have trained under Professor Dr. Albert Roden, Dr. Rotan, depending on what part of the world you're speaking from. So I grew up in a culture that was just good enough isn't good enough. Everything in Dr. Roden's circle was about perpetual optimization, perpetual improvement. There is no finish line was one of his famous quotes. And so needless to say, as a surgeon, I'm extremely anatomically precise and 100% microsurgical, lifelong, including training. 36 years in the neurosurgery game. And the entire time has been focused on, pushing and innovating and making better what I can make better within the canvas of neurosurgery. And about 22, 23 years ago, I switched focus from cerebrovascular skull base, which I was focused on, to the same exact application, but to spine surgery. So ultimately, that led to a deep commitment to minimally invasive reconstruction before that was a thing. And that's what I've been doing exclusively for the last 25 years.
Interesting. And do you miss the cerebrovascular and skull-based work at all, or not at all?
Great question. I loved aneurysm surgery, but the landscape changed so much, and when interventional started to appear, and we all know it's so important now, but I didn't really want to do that, and I was actually a surgeon that way. And in our community, I would have had to have changed jobs. I would have had to have left the town I was in and gone to a big destination academic center and committed only to aneurysm skull base. And I really didn't want to do that. It didn't work for my family. I was in Orlando already. We had a great presence here already. And so it was easier to just pivot. And honestly, and technically, I loved cerebrovascular skull base. As a technical neurosurgeon, absolutely loved it. I didn't love the emotional side of it. It was, for me, a little depressing, all that came with it, So I'm a lifelong athlete. I've always loved sports and sports injury kind of thinking and preventative health. I'm very holistic. And so spine was a natural opportunity because I saw such an incredible runway for improvement, not only on the technical surgical side, but even more importantly on the clinical pathway side, and how you get, a person in crisis and get them back to full performance was really a private goal. And so ultimately I deal with a lot of athletes because of that.
Yeah, interesting. It's just a question because I also had a lot of interest in vascular, and I've been doing vascular for a long time, but then I had to change to spine just because of the market. But have you ever had a point that you thought, okay, I mean, I wasted so much time or many years doing something, and then it's between cerebrovascular and spine, it's pretty much like career change.
Yeah.
Have you had that feeling, or what's your advice for people that might be stuck into one position for a long time in one subspecialty, and then they might be forced somehow because of the market changes to change subspecialty, and they feel sorry about what the time they invested and the effort that they invested in such subspecialty.
You know, it's funny that you framed it that way because that's exactly what I kind of just said I did. And but I found maybe it's a rationalization skill that I was born with, but I don't think so. I think what I really realized is I was doing brain surgery up here and I was doing spine surgery down here. And so when I really, really reflected on the situation that, life and the ecosystem of radiosurgery and interventional encroaching on the surgical subspecialty of cerebrovascular skull base in a private community, I saw that I could use brain surgery techniques and I could steal from cerebrovascular and skull base techniques to enhance spine surgery. And I saw it as a much bigger runway.
Mm.
So once I pivoted that way, it was it actually became more
Mm.
exciting because I immediately had a pioneer role in next generation spine
Mm.
surgery. And, and one of the things that is so striking when you really look at it is the variance from best of class recovery profiles in spine to typical traditional recovery profiles. And we've really, I do 100% outpatient, and that includes multi-level
Mm.
reconstructions. And I know in the UK that's not exactly looked up to, but the reality is the journey that I had was I founded and conceived the first federally certified spine center of excellence in the East Coast United States, and it was here in
Mm.
Orlando, and we did it under a big hospital umbrella system, the Orlando Health System. And what we learned in building this center of excellence, if you will, it was all through data tracking and data matriculation, but then a perpetual clinical optimization strategy. We got our lengths of stays in the first couple of years down from 3.6 days down to 1.4. And people say, oh, it's all about money. No, it really wasn't. It was about being out of bed a few hours post-op. It was being ambulatory quickly. It was having no Foleys. It was not getting
Mm.
transfusions. It was, guaranteeing that you were reducing the number of medication, not only received, but the errors because of the medications received. And every piece of the puzzle got simpler and simpler and simpler. And then eventually we evolved to a point where the clinical pathways had improved so much that, wow, people were leaving day of surgery. Well, it didn't take long before it occurred. We had data to prove it that our outcomes and our complication rates for people that went home day of surgery were so much less than people that stayed in the hospital overnight and beyond. And it was for all of those secondary, people are independent at home. They're walking, they're going up to the bathroom by themselves. They're walking outside. The homes are, even if they're dirty, they're dirty relative to them. They're not dirty relative to a
Mm.
hospital with all of the different bacteria. Our infection rate dropped to zero. I mean, overnight
Mm.
by doing outpatient surgery. So, for our perspective, I would rather do surgery in an outpatient environment, reducing the inherent risk of complications. And if somebody does need to be admitted, we can still admit them to the hospital for aftercare. But, most of spine surgery patients are healthy people in a spine health crisis. They're not sick
Mm.
people. And it's a different zone when you have, critically ill people with epidural abscess or TB or, cancer or, that's a different complexity. But 90% of spine surgery isn't that. It's degenerative cervical and
Mm.
lumbar. And those are healthy, well people. And so anyway, there's so much room for ascent when you really look at it objectively
Mm.
like that. So and that's how I viewed it, and I pushed really hard. And so we optimized our T lifts, we optimized the way we do cervical approaches, and just kept getting better, better, better. So it became pretty fulfilling.
Great. So I would just I put this at the last of my question, but I'll probably go with this now, given that you mentioned the inpatient versus outpatient, because that's like a massive change in the mindset and the practice, which
Right.
definitely means that you challenge a lot of the existing systems and workflows. It, how would you advise centers or surgeons across the world on how to adapt and how to implement and you're saying that it's 100% outpatient services. Does that include anything?
For
Yeah,
me
yeah, yeah,
right
yeah.
now, it does.
So that
Yeah.
includes
Yeah.
simple discectomies, ACDFs, anything like that would on
Yeah.
same day.
Th- 3-level ACDFs or arthroplasties, up to 2-level lumbar
Mm,
T-lifts. I do definitely micro decompression, cervical lumbar, are completely included. But for me these days, that's my profile. That's all
mm,
I do is cervical and lumbar micro reconstruction and decompression. And but the evolution towards that isn't okay. Let's just do everything we do now and let's take it outpatient. That will fail
mm,
miserably. It starts with this sort of optimization guard where the little things matter. Like it starts with, so right off the bat, length of case, improving efficiencies, improving your team's performance, making sure that you're not throwing away time in the OR,
mm,
which increases fluid flux, increases blood oozing, increases blood loss. For example, one of the simple things is I slowed down to go faster. I open with the microscope now. Because why? Because I don't have any oozing when I'm closing. It's completely
mm,
dry at hello. As I make it through the planes of my approach with the bipolar and Bovie, I'm eliminating any and all bleeding as I do my approach, which is X-ray guided, extremely small. Complex lumbar reconstructions are less than an inch incision 100% of the
mm,
time. And it's just a combination fluoroscopic microsurgical approach the way I do these things. But zero blood loss inherently improves so many
mm,
things. Lowering the speed of the time of surgery really allows people to wake up more predictably, faster, less fluid flux, less need for a Foley. Second, you get rid of the
mm,
Foley, you eliminate a lot of problems. The better the pain control from less invasive surgery, the faster they're up out of bed. Faster they're up out of bed, the fewer DVTs, the fewer pneumonia, atelectasis, complications there. Needless to say, in the U.S., they have this funny tendency. I learned it pretty quick in the process of the Center of Excellence, where the nurses in the recovery room, are told we have to do a pain score in recovery room. So they would wake up a completely sleeping human, sternal rub and all, and say, okay, what's your pain score? 10, 10, 10. Totally disoriented post-op person. And the reality is, why are you waking up a sleeping person to ask if they're in pain? They're
mm,
asleep. They're fine. Do not give them Dilaudid when they're already asleep. That's
mm,
ridiculous. And so little things like that became obvious. And so the pathways changed from cookbook, old school, to as needed, smart, progressive. And as that happened, people were walking 200 feet within 4 hours of surgery, 98% of the
mm,
time. Well, that's step one. Once you get to that metric, now you've got a different recovery profile, because really peri-op pain is worse day two than it is day
mm.
of. And so if you already build the emotional confidence of ambulation and going to the restroom and eating and all that's happening on day of surgery, you've got a much different recovery profile right out of the hatch. So as you start navigating that within the hospital and you get yourself closer and closer to a day or two needed, it's not like we're kicking people out don't that need to be in the hospital. And that's the assumption if you're in, a very
Yeah.
stubborn culture that says, oh, this is criminal. How could you do that? It's not about the money. No, you don't understand. These people want to sleep in their own bed. They're actually, you just took your clinical capabilities to a level where they can. And when I have an artificial disc, I had
Mm,
surgery. I was out of there in an hour and a half. I slept in my own bed. I had my own dinner. I was with my kids. I was with my
mm,
family. It was perfect. I took a 3-mile walk that afternoon. I, I did not want to be in the
mm,
hospital.
mm.
So anyway,
And as you was talking about the surgical efficiency or trying to speed things up, because some people would think, okay, I mean, for me, thinking about doing, let's say, a lumbar discectomy and try to get it done within 45 minutes or 30 minutes, they might think, okay, that shouldn't be my target as a surgeon. It should be, how can I do the operation well? But how do you combine both? Like, how do you reach to the
Yeah.
speed without compromising on the outcome?
By having speed where it counts. In other words, you don't rush the mission critical things, but you eliminate waste. And one of the easiest things to fix in surgical healthcare is wasted time. Getting the setup wrong, getting the organizational map wrong, getting the tools wrong, having the Mayo stand wrong. If your transition zone isn't prepared and you're waiting for things, or you're asking for something you use 100% of the time and they forgot to do it, you're losing minute after minute after minute that adds up to big chunks. I actually slow down on the important stuff. I took a journey through motorsports racing, and when you're on a straightaway, you're full throttle.
Mm.
You're just flat on the throttle. You're in a braking zone, you're anything but full throttle. And surgery to me is the very same thing. You actually want to slow down for the critical stuff, but that means you can't afford low accuracy, precision, or efficiency on the straightaways. You need to take advantage of the easy stuff. And, that's kind of what I meant with I open with the microscope. I take care of bleeding as I go in, because I know on the back side of the case, I have zero oozing, none. And, maybe I'll lose 10 cc's, 20 cc's in a lumbar recon. I'm using a bipolar on epidural veins before I rip them. It's a different philosophy. When I was young, cobs to muscle and scrape, 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 and pack, pack, pack. And, yeah, you can do it that way. We all did. But the it has consequences, and it also increases pain scores, and it also increases length of time to recovery, and gives a nice fertile bed for infections, and there's so many things about it. So yeah, no, I'm not a big advocate for rushing the important stuff. On the contrary, I like to slow down the important stuff, but speed up the obvious automatic stuff.
Yeah, that's great. I mean, because if you don't have this mindset as you are operating, and you think, okay, how can I, eliminate all the unnecessary moves, or maybe even side chats or unnecessary steps, then it makes things much quicker. But a lot of the surgeons will just operate without this mindset. I think it requires a lot of mindset training so that you can focus. Okay, how can I make myself better every time in terms of speed with efficiency? So I mean,
yeah, baby steps, little incremental baby steps, not big. Nothing ever happened quickly. The people that watch us from afar think, wow, how did you get there in a day? We didn't. We got there over thousands of cases, and little micro expressions that you accumulate, and this works, this works, this works, you go. Well, you know what? That didn't add anything. Okay, well, we're not changing that then. And you're constantly doing this game. But to your point, I think it's perfect to say, yeah, mindset. The mindset of perpetual improvement, perpetual optimization.
I can tell you like loads of stories about the wasted time, as you're saying, about a minute here and a minute here. It can be even more. It can be like 15 minutes here and 30 minutes here, and you're just waiting for a porter to grab a bed to get the patient out, and you're waiting for a nurse to grab a piece of equipment that is stored somewhere else that you know nothing about, and it takes so much time, and then you end up what you can do in an hour.
No, and as the surgeon, you're managing a whole day. We all like to say we're 100% present in an episode of care, but that's not exactly true. We're extremely stressed because we have multiple episodes of care in a given amount of time that we have to do. And so the stress builds, and do things go better or worse in a stressed environment? Well, usually they go worse. So the more ahead of it you are by a mile, the more safe you are.
Perfect. Let's jump into the MIS. You're a big fan of MIS, a big advocate for MIS techniques.
Yeah.
And I think that definitely, I mean, there's a lot of people are moving towards MIS techniques. How do you see this has changed over time, like 20 years ago to now, and why why would you advise people to learn, optimize, and do MIS techniques? And after that, we will jump into the IMAS 360, and we'll probably talk about it. But let's just about overview about what happened over the last 20 years in terms of MIS techniques.
Yeah, when I was the senior resident, so PGY5 in neurosurgery, 7 years in the United States in the early
Mm,
90s. We were one of the IDEs for metrics, or the MED, microendoscopic discectomy. It was basically the Medtronic sophomore-Danek tube with a little camera on the end. And eventually it became tubular micro decompression without the camera. But I grew up in that environment, and I was a cerebrovascular fellow and skull-based fellow under Al Roten. So I was already microsurgical. So the way I saw it, it was how much it wasn't like I consider what I do now to be open,
mm,
but it's really what do I need? Um, and so it's a different exercise to take more than you need and then reduce it to what you actually need than it is to go from open to MIS. Like, I personally don't like tubes. I grew up with tubes and I quickly went away from them. I use a Williams retractor, a Williams microdisc retractor, and my assistant always holds it at exactly the angle I want them to. And but I get to move very agilely and in real time. But at the end of the day, and when we get into IMAS, it'll be more clear, but I think of it more in where do you want to be, when, and why. So if you know you're only working, let me pick
mm,
L45 and let's say it's a left-sided target and left-sided symptom complex. Do you need to be working on the right side for that, the whole case? Or is it when are you on the right side? When are you on the left
mm,
side? So at any given time, my retractor is only where I'm
mm,
working. It's not a big, open, bilateral, muscle strangulating, destroying retractor system. It's a small Williams retractor, very specifically focused and angled to that quadrant. When you get into full form IMAS, we're really working one segment at a time, which means pedicle to midline if you're only on one side. And over the years, that anatomy of pedicle to midline, which is a tunnel of about that turned into 7 zip codes, 1, 2, 3, 4, 5, 6. Preforaminal, foraminal, extraforaminal low, foraminal, preforaminal, and then central canal ipsilateral. So those zip codes all have expectations and predictive analytics for what you're dealing with, what you're finding, what you expect. And so your macro view becomes
mm,
micro. And to a open surgeon, it's MIS, but you can still be an open surgeon at that level of precision and
mm,
detail. So I would argue it's more about learning how to be comfortable with less. But it doesn't really matter whether you're doing, like, I know people that I say are doing MIS with 2-inch incisions for a single level. It's the way they handle the tissue, the way they handle the muscle, the precision of the bone work, the amount of bone work. It's not a 90-degree box cut by definition. You can actually, for instance, when you do a medial facetectomy, we all say, medial, inner third,
mm,
whatever. Well, you could actually not take any high and you could take a lot low, and that's even more MIS than a medial facetectomy,
mm,
by how you do a polyaxial approach and undercut the internal foramen. And so the little subtleties of how you do your bone work matters. Like, I haven't done a traditional open laminectomy in almost 15
mm.
years. I do an ipsilateral
Bingo.
hemilaminectomy and then a contralateral over the top versus
Mm,
internal. But there's so much thickness in the contralateral lamina. If you take the internal 80% of the contralateral lamina into the facet and have a bird's eye view out the foramen, it's a great view. You preserve 100% of the dorsal spinous process
mm,
and the interspinous ligaments and the muscular attachments. Even how you strip the muscle off the dorsal spinous process. If you truly go to the deep vertical midline, you're stripping all the neurovascular bundle for all that musculature and eliminating all proprioceptive function of those
mm,
muscles. If you leave a little cuff and you go a finger breadth lateral and obliquely go down to the base of the dorsal laminar arch, now you're only decorticating deep, not proximal, and you're suturing the fascia proximal, that muscle is going to be alive and it's going to be proprioceptively intact, and it will assist that person in functional movement and performance for the rest of their life. That is a MIS philosophy. It's not about the size of the approach. When it started, it was all about the size of the approach. It turns out these days I don't need much, but I actually have a bigger incision in 25 than I did in 2010, because in 2010 I was in that mindset. It's about the size of the approach, but I was still learning about all the different philosophies of MIS, which really was muscle handling, tissue handling, bone handling. All the other things are more important than the skin incision. I mean, it's the bottom line.
Yeah, interesting. And you invented the system, which is IMAP. How did that start, or what made you think, okay, I mean, I need to develop something? So where did the idea come from, and what's exactly IMAS 360 for people who don't know about it, and how did that change your practice or other surgeons' practice?
So the formal system, I'll start there and use it as a destination, is just a microsurgical mini open TLIF, a micro open TLIF. And so basically, I started that with Synthes in the early 2000s. Then Synthes was acquired by DePuy. We had Click's headless screw system and an old banana allograft cage in V1. And then with DePuy, it was a T-PAL Peak rotatable cage connected to the matrix screw system, which was another headless screw system. And then eventually I went with Biedermann Motec, who had been DePuy's engineering manufacturing partner before the Synthes acquisition, and they got it right. At that point, it was one tray for my screw system, one tray for my cage system, and it was Telix K interbody system coupled with Moss 100 and the Biedermann system, and that became IMAS 360. But so how did it start was really important. I ironically, I had a 76-year-old woman arrive in Orlando from Chicago, Illinois. She had had 5 previous micro decompressions at L4551, all with zero relief of acute agonizing radiculopathy. And it sounds like, well, how is that possible? Well, she had severe degenerative and idiopathic scoliosis at her age. She had significant osteopenia. She was so twisted and turned and petite. As I received her, I was, this will be a chip shot. No worries. I got her on my OR table. I couldn't see anything. You couldn't. Everything was so distorted. Her iliac crest bone was adjacent to the lateral facet at 4.53423, and so I realized I put AP fluoro in. I found the L5 pedicle in AP fluoro and superior end plate, and I basically did a kyphoplasty approach to a small pedicle screw, and put it right down, and then I used the screw as a buoy. That was in 1998. And that move, I ended up doing a small microdisc incision. I immediately found the screw. I knew exactly where the foramen was. I found the nerve root. I followed the nerve root around the pedicle up to the 4-5 disc space. It was a caudally migrated disc fragment, came out. It was an easy case once I had the buoy in. That became IMAS. That putting that buoy in was the basis for headless pedicle screws. And because at that point, I started putting my screws in first, and I started using headless pedicle screws well placed fluoroscopically in the pedicle as a way of knowing exactly where I was in 3-dimensional space at all times. If I knew where the screw was anatomically, then I knew where everything around it was. And so that became the basis for a perfect facetectomy. All of a sudden, I didn't need to chop out the whole facet. What I really needed was A to B, trapezoidal cut, perfect facetectomy, every time hitting the disc space, never looking. I do my T-lifts before I do I played with sequence in those days. And so instead of doing my T-lift with everything exposed, that quickly evolved into, no, do the T-lift first, then you get an indirect decompression. Is it easier and safer to do a decompression direct before or after a TLIF? Turns out it's a lot safer to do it after you've used indirect decompression to your advantage. And many times you find you don't need to do as much of a decompression directly as you would have done if you had done it first that way. So playing with sequence, I ended up reversing it to screw first, facetectomy for interbody second, and then direct decompression, the most important part of the case, last. And then lock, load, assemble, and get out. That became a very reproducible, redundant pathway, and that's IMAS TLIF basically. It's micro open to me. It can be done 2 inches. It can be done half an inch. It depends on comfort zone of surgeon, but by definition, that skill set minimizes damaging. I consider it the evolution of the non-deconstructive spine reconstruction. The more you deconstruct, the more you affect the math of healing.
And when you say that you do the cage before or the TLIF before the decompression, do you find that difficult at any point to put the cage before doing the decompression, or do you find that the decompression might be difficult after putting the cage? I mean, vice versa. I mean, there's
the trick is so many people are scared of the TLIF because they don't handle the TLIF like a skull base approach. So one of Professor Roten's things was take bone, not brain. Don't pull on the brain if you can drill down the petrous apex. I mean, that was, or you're coming down the clinoid, drill out the clinoid before you start manipulating the paraclinoid carotid. I mean, that's just so obvious to a high-level cranial neurosurgeon. But then in spine, all of a sudden you're intimidated by the L5 nerve root. And it, it can become a little ridiculous quickly. But so imagine if, for the sake of argument, you've got a really collapsed L5S1 and it's really crowded, plus you've got that subtle compression of the pedicles of 5-1. So L5 and the disc space overlap lateral in that margin. The reality is it's arbitrary where we put the S1 screw. So imagine you put your S1 screw on a severely collapsed L5S1, low and lateral in the S1 pedicle, and you do a Roten-esque, Shakar-esque, basilar decompression of the high medial pedicle, and you get real low at that level. What you ultimately want is you want the template to be perfectly medial, not far enough so it's in the central canal, but not creeping lateral where you're going to hit the nerve root. You want it to be exactly where you are, lateral to medial. And then you want it to be flush, so half of the template is below the center disc space line and half of it is above. At that point, it could be a tall layer or a collapsed layer. It doesn't matter because you approach it vertically and perfectly. If you preserve all that bone, it pushes all your tools up to the foraminal nerve root. That's why people struggle. So how you manage the bone, you're putting back the segment, you're fusing and reconstructing the segment anyway. So what's the harm in taking a little extra bone low and medial so that you have plenty of room to put your interbody in? And that's the trick. That's the art, is the perfect facetectomy and emphasis on low medial. And knowing what low medial means, and that's one of the advantages of either a best of class nav system or a well-placed headless pedicle screw, which serves as a best of class nav system. Once you know where the screw is and you know where the pedicle is, you know exactly where the foramen around it is.
Interesting. So then, I mean, you continued up with other innovations and inventions. Now you are the founder of Expanded Existence. Again, right. If you don't mind just sharing with us, what's Expanded Existence? How did that again start? And what does it provide? And how does it help surgeons in their surgical workflows?
So the IMAS journey really was the canvas for XX, and you couple that with the Center of Excellence build out clinically. I ran the Department of Neurosurgery, and we built out the Center of Excellence, and we looked at clinical pathways and optimization and leaning the way we organize surgeries. And when you dive that deep into a perpetual lean optimization platform, you really learn how to shrink wrap the episode of care. And like I alluded to earlier, even I the matrix screw system that DePuy ultimately brought to market was 20 trays. I always wanted one tray for a screw system, and the Moss 100 was one tray. And Biederman did a beautiful job with that. They built Expedium, they built, the original Moss Miami systems. They did all the legendary stuff for DePuy Motec way back when. And Moss 100 was that system, but in one tray. So when you go through all of this and your focus is lean optimization of performance for every episode of care of surgery, you learn a lot about how to streamline surgery. So with that as the canvas, it became clear to me in the late teens, like 2019, that we waste so much time and tools and trays and sterile processing and consumables, and every piece of the surgical puzzle globally is massive waste, time, energy, and resource. And so at the time, artificial intelligence was coming around. We had some new imaging capabilities with mixed reality. I'm not typically a fanboy. As neurosurgeons, I think we all have the ability to be tool masters. So it's not about finding a fancy tech and making it work. It's about how do we take existing tech that might change our perspective, and how do we enable a process that we would not have had without it. So when I saw mixed reality, I immediately thought, wow, this is a portal to the sterile field. So now we have a way of getting onto the sterile field with infinite digital data, and potentially computer vision and all sorts of secondary potential features. So with the canvas of how do you make a surgeon better? Well, the number one easiest way to make a surgeon better is not to focus on the surgeon, to focus on the team behind the surgeon. I don't know a surgeon who honestly will admit that every case is done perfectly behind them. If you meet that person, they're lying. That's the biggest frustration, distraction, lack of focus. And it's not because people behind you are bad. It's not because they don't care. It's because they're using the same antiquity methodology of preparation, organization, and guesswork and memory that we've always used. But we're in an information age. And I saw the opportunity to build a software platform that created basically the surgery map for every surgeon's every surgery. So when you look at, let's say you have a special way you organize your anterior cervical decompression reconstruction. Well, how do you set up the room? Are you right-handed, left-handed? Which side are you using fluoro or not? Do you have some secondary x-ray system? Do you have any electrophysiological monitoring? If so, where does it go? Where does the microscope go? Every surgeon has their own preferences for everything. What is your Mayo stand for incision? What is it for exposure? What is it for retractor? What is it for, discectomy? The Mayo stand is the transition zone. That should be very specific to phases of a surgical execution. And so when you get to that level of precision detail, you're starting to feel like a Formula One pit stop, and is there anything on earth that should be more familiar to an F1 pit stop than surgery? I don't think so. I want every surgery to feel like an F1 pit stop, not because you're rushing, but because you're not wasting anything. You can't make up for waste. You just can't. And not only time, but organization, resource spend. One of the things I learned is I thought I was really lean. Well, it turns out we were opening 4 10cc vials of Surgiflow hemostatic agent every case. That's $800, or £1,000. What? Actually, it's only about 600 pounds, but still, it's that's out of pocket every case, every time. Turns out I only used 0.8 once I actually listened to the data. So we created a software platform that organizes every surgeon's every surgery so that the team behind them knows exactly what they're doing, not only what they're doing and where they're doing it, but when they're doing it. Where am I within the case? Where am I in the sequence? What phase of the case am I in? What tools are important to this phase of the case? And literally, when you put the headset on and bring that's for the scrub nurse. Imagine the scrub nurse has a a holographic image of every tool that you need before you ask for it. And they know exactly what you're about to need. And that's a well-done surgery map. A surgery map done intelligently is predictive. And then you add, the headsets these days have computer vision to them. So you're learning and you're recognizing tools, and the system and AI is analyzing tools and time stamping them and learning what do you use and what do you not use, and what percentage of use do you have, and how does that affect tray organization and design, and ultimately sterile processing. And is a piece of your surgical life wasted on sterile processing? Most surgeons would say yes. We have to wait an extra hour sometimes for trays that we probably don't need to be cleaned. Well, it turns out if you reduce the number of trays you're trying to clean, the whole system isn't backed up anymore. And then, again, it's just incremental baby steps throughout the surgical episode of care, optimized for the benefit of everybody, the patient, the team, the surgeon, the facility. So I don't personally see a harm in maximization of marginal gains, but XX is the marginal gain company for surgery. We want perpetual optimization of every surgeon's every surgery in all specialties. But for me, the canvas was IMAS.
I mean, I can see now the pattern of your thinking that it's leading to the different innovations that you have done, which is all towards the optimization of the workflows, which is really interesting and really I think productive. And it makes, if I think about it, like in the UK, for example, is within the NHS, something like this would probably save a lot of time, a lot of, would save a lot of money as well, and definitely will improve productivity, right. which is one of the big things that is affecting the NHS hospitals at the moment is productivity. And I think a big part of
we have a pilot project at Royal Orthopaedic Hospital Stanmore in progress right now. So we're real excited about that project.
Yeah, great. And when you talk about the number of trays for a certain operation, do you design those trays yourself? Because here in the UK, what happens is usually the companies would bring the trays for certain operation. Sometimes they might have those trays in the hospital if we have like a big flow of cases. Do you think who's responsible for that? Like as a problem in the pathway, is it the company? Is it the surgeon? Is it the hospital? Who should design those trays to make it more efficient?
So, you'll have the implant system trays, and those are different because they're created by the company, and typically they're this is here and this is there and everything's. Then you have your general tool trays where everything is dumped in there, and it's very customizable at a facility level. It's a little bit of all of the above, but I would argue that the surgeon needs to be present mentally. Even with the big, like Matrix, for example, it's an easy example because it was just stupid how many trays there were. Imagine being a surgeon out in the rural area and you ask to try that system and someone arrives with 20 trays. I mean, it's ridiculous for one screw system, and it's distributor nightmare. So I've always just gone, invested a little bit of time and emotional energy in looking through the trays. I need this, I need this, I need this. Get rid of all that. Let's consolidate it. Let's put it, and then I create the specials. Not every surgeon has the same latitude. I've always somehow been able to get, but I think it starts with trying and creating that mindset of, look, this benefits everybody if we're as lean as we can be. And throughput is better, access to care is better, backup and sterile processing is better. Inherently, if you have 4 trays instead of 10 trays, everyone's better. So I would specifically look at the implants that way. I would tell, and honestly, the sales consultants, I call them service consultants. They're there to make the episode of care better. It's in their best interest. And ultimately, it's less tedious for them if they don't have to carry back and forth too many trays all the time. So get them engaged and say, look, I want to streamline this to what I really need, most of the time, and then have a few things on backup that I might need, and then anything I absolutely don't need, get rid of it, and let them deal with that. On the general tool, same thing. I mean, be honest. Do I really ever use this? There are so many tools on the general trays that are just there,
Yeah.
and nobody ever uses them. And but it's clutter. It doesn't feel like it adds a lot, but it does because of the volume of it. And so it starts with being mindful. It starts with awareness, real simple concerns, and then a goal ultimately for improving patient care. And with that, it makes sense. It just runs downhill after that.
I mean, it's a lot to discuss in this, but I don't want to keep talking about it because it's one of the things that I'm interested in terms of efficiency and making it productive.
Yeah.
Let's jump into the business side of our career. You have had a lot of work in terms of neurosurgical entrepreneurship or spinal entrepreneurship. How do you see this affected yourself as a person? Do you see that made yourself as a better surgeon? Do you think that everyone should pursue a career or something beside being a surgeon and explore the business side of or the entrepreneurial side of surgery? And are there any kind of transferable skills between both? That's again a kind of an area of interest. And how do you see this has changed over years? Again, I mean, from again 20 years ago towards now, how the landscape of having neurosurgeons, entrepreneurs being in the market.
I think it's a category of pillar of a well-rounded surgeon's career. I think there are several pillars that are uniformly accepted, and an academic surgeon's career, they have their surgical hat, but they also have expectations about publication and research. So that would be an example of a acceptable surgeon breadth of performance. I think historically the entrepreneur, the business facing, has been looked down on by traditional surgery, but it's a form of leadership. It's a form of innovative growth. It's a form of educational progression that you can resist it all you want, but that's how we get better. And so I think it's a pillar. I think some people are brilliant at the research and paper manufacturing side of the equation, which is how you disseminate knowledge. And I'm not personally motivated that way, and I'm not very good at it. So that's not where I choose to go. I love I'm more of a scout archetype. My personal special skills are to push, to disrupt, to find better, to test little things safely. And my grandfather was a test pilot and a military pilot, and I grew up in that culture. I wanted to be an astronaut. I ended up in neurosurgery. So I think we're all wired to have different skill sets, but I think that's a pillar. I think administrative leads who are healthcare providers have a different ownership of administering patient care than business-minded people. And I think we have too few, medical professionals administering healthcare. And so I think we need to open up our boundaries a little bit. But I celebrate any doctor who rounds himself out, whether it be research and education or administration of healthcare or innovation and progression of healthcare. I consider them sort of secondary roles that every provider should learn. And I see a special value in the business entrepreneurial role, in the sense that doctors have lost a lot of their power, and they've lost a lot of their ability to move their environment on behalf of their patients, their community. And, the only way to get that power back is to be expert in that space. When the people that control healthcare know things that we don't know, it's impossible for us to navigate. And so I think if you look globally at medical environment right now, I think there's a lot of opportunity for, a little bit of a minor revolution and towards the next generation. I think the next generation, your generation, is going to be brilliant because you're asking that question now. When I started doing this, no, it was actually not okay, and nobody was asking. A lot of people are asking right now, and I think it's an opportunity for providers of all types to get some control back, get voice back, get leadership back at the end of the day. And so to me, for whatever reason, the research and education is so easy for people to say, okay, that's a good thing. Administration came next. Business entrepreneur innovation has been, Cinderella, but I think it's better. I think it's there now. I think everyone gets it.
Yeah. I think there is a kind of difficult relationship between anything that relates to money and surgeons or doctors. They always kind of fear of getting in activity, not to being criticized in that way. But as I said, I mean, there is a big move now, especially with everyone recognizing that you cannot just be a neurosurgeon or a spine surgeon or any kind of surgeon. You have to be a surgeon plus doing something else. This could be a research or could be other opportunities. Yeah, definitely, hopefully that can lead to kind of taking back control again of the healthcare system.
And to your point about the money thing, you're spot on. But the problem is there are too many surgeons that make it about the money. The pseudo consultants, the ones who, what's in it for me because I'm using your system, versus the true innovators. There's a difference. And I can say with great clarity, whether people believe it or not, I don't care. I have never thought about money. I'm a neurosurgeon. I'm okay. I've always felt that way. I don't think that, and it turns out if you do something exceptionally well or you develop something, money ends up working out too. But I think we have to be just a little bit more clear why we're really doing it. And if we're boldly and proudly saying, look, I want to innovate, I want to scout, I'm not satisfied. I hate inefficiency. I'm passionate about this. I think it's perfectly reasonable and fine to be extremely passionate about something, but you have to be bold enough to say it out loud and not hide behind it because of the stigma of the money. But there is a little too much focus on the money. No question. I agree with that.
And what do you think? I mean, because I always think that the healthcare system needs disruptive ideas. What are the 1, 2, 3 things that you think needs disruption within the healthcare system?
Communication in episodes of care is a big opportunity. And again, not just, there tends to be silos. Look at a surgical episode of care. You've got SPD, you've got peri-op, pre and post, you've got anesthesia, you've got scrub nurses, circulating nurses, you've got OR desk, you've got floor, you've got all these different areas, all interdependent, and none of them communicate. When was the last time the SPD people talked to the live surgery team? They just don't. Everyone's siloed. So improving inter-episode communication is a big thing. Onboarding and training, massive right now because of retention of staff. New staff comes along. They're not familiar with you. They're not familiar with your procedures. How are they going to be onboarded? It turns out that's something XX is really good at. We can take someone who's never worked with a surgeon or a procedure and onboard them because of a visual digital map in less than a day. It's like Google Maps for surgery. So we turns out we're a really good aid for onboarding and training. Organization, logistics. I'm a little biased on the patient experience part of it. There are so many barriers to entry. The EMR process, memorialization of patient information has really contaminated information technology in healthcare. I like IT that's going to improve human performance, not so much the memorialization of what happened. But unfortunately, a lot of healthcare providers assume that anything IT is going to steal from them the way EHRs have stolen from them. And it doesn't have to be that way. There's a lot of applied healthcare stuff coming. And that's the real opportunity from a data, AI, mixed reality standpoint, is things that make clinical jobs a lot easier. But making implant systems better, making biologics smart. There's so many unmet problems that we can make better. So genetics, biological engineering, genetic engineering. We need to stop operating on GBM. Glioblastoma is a genetic and biological solution waiting to be found, and I'm hoping quantum computing and AI is going to help accelerate a dent in the survival rate of glioblastoma multiforme, because it's not a whole lot better than it was in the 50s, and that needs to change. So yeah, there's so much, but I think as surgeons we need to push. We need to lead the charge and innovate and push and disrupt and raise our voice like we used to, and not be so worried about not stepping out of bounds. That would be my bias.
Yeah, perfect. So for all the surgeon entrepreneurs out there, loads of ideas here you can focus on and get your journey started. You're a professional racer. Which one do you think needs higher level of concentration and quicker decision making? Is it racing or surgery?
Surgery, by now. Yeah, now where it counts.
Opposite,
surgery.
To be honest.
I think when you get past the fear of motorsports, then it's a controlled event. It's about the details. There is a point where, am I braking at 180 feet or at 160 feet? And the consequence of being wrong is you might skid into the wall. So it matters, but once you're dealing with those small marginal improvements, it's just a tiny change. You're not going to jump to 160. You're going to start at 175. So, that was a little close. Okay, I'm not doing that next time. It's you get pretty comfortable pretty quick. What I didn't like about racing was other idiot drivers who try to ruin your race. It gets pretty hostile out there. So,
perfect. And we'll probably, it's interesting discussion. I think I can probably keep talking with you for another hour, to be honest. It's all interesting points. We'll just finish off with your 3 lines of advice for next generation of neurosurgeons, spine surgeons who are watching us. Top 3 things that you would advise them, or 3 things that you would love someone have advised you these things 20 years back.
1, eyes wide open. Just take it all in. When you finish training, you're not really where you want to be. You're just starting. That's your learner's permit. That's your opportunity to figure out who you are. Celebrate that. Learn who you are. Figure out the small ways you want to make your role in this industry better. And it's infinite, the possibilities. So celebrate it. Enjoy it. It's a journey. There is no end point. And I think 2 is balance. Everybody wants you to be so totally dedicated that you lose your value globally. I mean, being physically fit, being emotionally fit, building family, building community. Your relationship to your community is so critically important to your role as a surgeon. It's not just the surgery. I think we put too much emphasis on the surgery and not the role we have with the people that are the opportunity that surgery brings us to. So it's that, balance. And then 3rd is find something to fall back on that is parallel to your journey in healthcare as a healthcare provider and professional, because that's where the passion, when the boredom kicks in, when the burnout kicks in, when the secondary things just aren't as exciting as they once were. When you've clipped your 50th aneurysm, it's not as exciting as it was your first 10. Everything it becomes a little less important as you get older. But if you always have this secondary in parallel thing that you're developing and building and passionate about, it's a brilliant sandbox to play in healthcare. It's endless. And I don't really feel like I've ever had a job. There have been times where it felt like a job, but then I pivoted. but I love this space. I love the opportunities for change, for pivot, for growth. I think we tend to be too grit strong, so we stay in our lane too long, but and that's okay. But I think keeping an open mind, but understanding that healthcare is just such an incredibly important industry, and lifelong, we're going to have the tools to influence it in one role or another. So just get used to playing different roles. It's not just the surgeon hat.
Yeah. So it's not wrong, or it's not to get outside the comfort zone or outside your box. Just get out and try to learn new,
Yeah.
implement it, and yeah.
Yeah, I call it, once upon a time, get comfortable being uncomfortable. These days, I'm uncomfortable feeling comfortable. Okay, what's wrong with this picture? I need to stir something up. And I would argue that I'm way better this year than I was 5 years ago at practicing medicine because of my diversification. I think it's given me perspective. It's given me empathy. It's given me insights into things that as the pure surgeon, I wouldn't have grasped. So I'm eyes wide open. The older I get, the fourth thing, I'm sorry to bore you, is this. I am learning at a pace and rate because of AI right now, faster than I've learned in my whole life. And I'm 61 years old, and I'm learning more per day now than I ever have in my life. And I think that's amazing. So embrace the tools, but learn how they are your tools. They're not this autonomous creature that's going to inhabit the earth and take over. These are incredibly powerful tools for exponential growth of intelligence as humans. And so embrace it. Make it a tool.
Perfect. Thank you. Thanks very much for taking the time. It went on, more than I expected. I'm sure that our audience will find this very interesting discussion, and we can build on that. And I'm sure that we'll probably get you back soon on the podcast again to discuss more things. Thanks again.
I hope it's helpful.
Definitely, I'm sure. Yeah. Thanks for joining. And for our audience, please make sure to watch the previous episodes and to support us on the different social channels. Thank you.
Thank you.